So about a year into our project, we added a fourth dimension to the project, and that was integrated service delivery using teams. And you could feel the energy in the room just take off. And all of a sudden, people said, yeah, that's what's happening here. And as I started to think about this, I recognized this model as another model by Ed Wagner, only it's upside down. And I see this in a lot of your documentation as well. This has actually become a very common, popular model for chronic disease management. And so the infrastructural pieces that we'd worked at were the organization of care and the clinical information systems. And these are clearly infrastructural in support of what comes next, which is proactive patient practice teams and patients themselves. And I think what we've recognized is as each of these starts to develop and mature around information systems and self-management, it changes the relationship of all of that. And the practice team changes along with that. So, what else did we learn? We learned that upstream changes make all the difference. What do I mean by upstream changes? So this is our model of the service delivery changes that we made. And when we first started, we were concerned that we would change the way docs work, and maybe by infusing teams, we would lose relationships with our patients. And in the end, when we actually looked back at this, we recognized that up here, the actual acute care and the emergency care, the way we take care of heart attacks and strokes and asthma, didn't change at all. Stayed exactly the same. So the medical management that we do with our patients was the same. What we changed was case management. We really built a lot of team-based care programs. And at that time, we focused on disease entities. So we got an asthma team and a diabetic team and a hypertensive team. But we also really improved the ability for home care to support these people outside. And where we really put effort in and money was in this self-management piece, in self-care and wellness. And I always thought, you know, billboard medicine, a billboard that says lose weight and quit smoking is pretty ineffective. I didn't think that that was going to make much difference. But what happened when we did that was that our hospital utilizations dropped dramatically. So we had gone from 110% occupancy to 78% occupancy. So we said, okay, let's cut our beds. So we went from 27 beds to 19 beds in our acute care facility. We still were at 78% occupancy compared to the control communities that stayed at the over 100% occupancy. What we did find was that our morbidity in the hospital and the length of stay in the hospital just took off. It was quite dramatic. And thinking about that and looking at that, what we realized we were doing previously was admitting people for 2 or 3 days to figure out what was the matter. It was the most expedient way to do it. Now we had enough resources in the community that we didn't do that anymore, and we eliminated those short-term admissions, and those people that did get in the hospital were really sick and needed to be there. Equally, we had a dramatic decrease in emergency room visits, and our lab utilization, even though we were doing hemoglobin A1Cs out our yin-yangs, the lab utilization actually decreased because of that. What we were surprised at and actually a little dismayed with was that the absolute physician visits went up. Here, this is supposed to help our lifestyle, right? And we were actually seeing more visits. And Alberta Health was actually following along, and the unspoken presumption was that when you put physicians on salary, they get lazy, but it didn't actually happen. However, the intriguing thing was the actual visits per patient dramatically dropped as the rates of visits for the non-physician services really went up. And so at the end of the project, we actually had a return visit rate of 2.1 visits per year compared to the control communities and our return visit rate of 5.6 visits. We find that a little awkward to talk about because it really is a bit stark when you think about a fee-for-service environment and an alternative payment environment, but we really pay attention to this particular piece of data, because I'll show later how we've actually used that to define how much physician supply we actually need in our community. I wanted to use this as an example. We chose asthma as one of the community-based illnesses that drive people to the emergency department. Patients themselves decide if they're going to go. It's not that we actually invite them back to the emergency department. Asthma, in southern Alberta, asthma is a big deal. It's always been in the top 3, often the #1 reason for patients to come to emergency and to be admitted. So we thought it was a nice monitor of how things were going. Within the first year, we dropped our emergency room visits by 61%. There were 2 things that we did in this asthma project. We hired a nurse, and the nurse, and we referred every asthmatic that walked through those emergency room doors or came into the clinic. We referred them all. And this nurse, first of all, then got a pretty clear picture of who had asthma in our community, and she proactively followed them. And if somebody was really bad, she might follow up twice a week. Or if somebody wasn't bad at all, she may say, okay, well, let's see you again in a year. But she really followed these people because we didn't want them to fall through the cracks, not show up again for 6 months, and then show up at 10 o'clock at night in emergency department. So that was the case management piece. The second thing we did was hired a respiratory therapist. And that respiratory therapist just taught these people how to manage their asthma. And it was quite interesting. People would come with asthma with this little dog-eared piece of paper that was under the fridge magnet back home, and they'd say, Doc, you know, it said that if my peak flow did this, then I do that, and then I tried that, and then this happened, and now it says I'm supposed to be here. And sure enough, it was a very appropriate visit to the emergency department. And so that was really quite interesting and very sustainable. And when we started to do our data again, we saw another drop in this last year. And we're now down to 78% of our baseline, where the control communities have now gone to 115% of their baseline. And I think that's even going to fall even more in this next year. And so we thought about what it was that we've done that's different. And there's, I think, 2 things there too. First of all, we have now got access of less than 3 days to the next available appointment. Often we talk about access as being important for the quality of care that patients get, and I think this is an indicator, and we're going to work a little bit more at this, to say that yes, when you do provide access, the quality of care you provide improves as well. The other thing we've done is really started to focus on primary family practice teams. And so now my nurse and my office assistant, my team, is starting to do a lot more of that asthma care than the asthma team, which was somewhat remote, was located in the hospital. We're drawing these patients closer to us, and that's been another important piece. Instead of having this disease entity that this new specialist group takes care of, we're actually focusing on the family doctor and that family practice team. And I think we're going to see that even improve even more. So what else did we learn? Teamwork, role identity, followed closely by role clarity. That is really crucial. During the Tabor project, the University of Lethbridge Faculty of Management had somebody sit at the back of the room for every single meeting we had. It's a bit eerie to have somebody sitting there typing on their laptop and not really know what they're saying about us. They published this really eloquent paper by Shrem. It came out in December. That they were going to title Professional Identity Under Reconstruction. And it really is quite fascinating what happened, because there was this sense of change as we matured. You can build teams by hiring more nurses and a pharmacist, and let's get the physiotherapist into the clinic. But you need to develop those teams. It's more. Developing the team is much more related to our professional identity than we really recognized. And that shift was most difficult initially for the docs. We struggled with that. We came from a traditional role where we do everything. Only I can do it, because I can do it best. And so I'm going to do it all. There's no way. There is so much to do, you just can't do it all.